Thank you very much. Thanks for the invitation to speak again. I just so much love coming to this meeting. It's a wonderful time. I get to see old friends. I get to see old patients again, and everyone's doing well. It's a nice time of year. The weather is great. The bikers are out. The plants are growing new greens and all that. It's just wonderful. So what I'd like to do this afternoon is just very briefly summarize a little bit of information, kind of maybe what I might call the most frequently asked questions. When patients with myeloma come to the office, what are some of the most common questions they ask? And I'll try to anticipate some of those questions. And then we will have a longer question and answer time where we can talk about some more specific things. So my background from myeloma, I remember when I first encountered myeloma in a clinical context. This is more than 10 years ago. And at that time, myeloma was a dismal disease. Back 10 years ago, a lot of patients were very ill from the disease or from the side effects of treatment, and the outcomes were not very good at that time. Over the past 10 years, the disease has changed a lot. Probably, I would say maybe 3 or 4 things have made the difference. You've heard about all the new drugs, the Revlimid, the Velcade, and so on. We've also learned a little bit better about how to manage side effects of the older drugs. So we've learned a little bit more about how to handle dexamethasone, prednisone, their side effects, transfusion therapy and how to avoid transfusions and so on, how to treat infections, how to prevent infections. All that's very important. And then also about stem cell transplant, which was not available many years ago, but is now an important procedure in the treatment of many patients with myeloma. I'll spend just a few minutes describing what stem cell transplants or bone marrow transplants are about, and then I'll just probably take some questions. So this morning as I was driving in, they were talking about Albany, New York. That was in the news again, and I was thinking to myself, somebody who spent all winter in Albany was very unfortunate. The weather was bad and all that kind of thing. But I don't know if you've heard, somebody there has just won the lottery. $316 million. Yeah. So I said to myself, whoa, that's quite a bit of money. And in a short while, all the accountants and lawyers are going to be meeting with that person. One of the questions that person is going to be asked is, do you want all your money now, or do you want it spread over the next, 10, 15, 20 years, something like that? And when I think of bone marrow transplant, that's actually a useful way to think of bone marrow transplant. You've heard about melphalan, which is an old medication, but still very useful in the treatment of myeloma. And the traditional way in which melphalan is used is it's a low dose of medication given continuously for months and months in cycles, sometimes for years, as a way of controlling the disease. Well, there's another way to give melphalan, which is to take a lot of melphalan. So the standard dose is 4 milligrams, but you could take 200 milligrams per meter square of melphalan. That's a huge, huge dose, and give it at once, all together in one day. What that does is that it hits the myeloma cells like nothing else can. It gives them a big dose of chemotherapy. They can't handle it. And it's probably the most damage you can do to myeloma cells in a single treatment. There is some collateral damage, and that's what stem cell transplant is about. So when you give such a big dose of drug to a patient all at once, they are going to have some side effects. They are going to have some nausea. You can control most of the nausea these days. They will have some fatigue and tiredness. You can help that a lot these days. They will have some risk of infections for the next 2 weeks to 3 weeks. You can control that very well these days. The one thing you could not reverse if you didn't take precautions, would be that they are bone marrow stem cells. And these are the cells that make and manufacture the other good bone marrow and blood cells. Their bone marrow cells would not recover if you gave the patient such a big dose without preparing them. So the way patients are prepared is ahead of time. So a month or somewhere like that before giving them this big dose of melphalan, you would collect stem cells from their bloodstream, freeze those stem cells in special refrigerators, and then after giving them the melphalan, you could give them back those stem cells like a blood transfusion. Those stem cells will find where they need to go. They'll replenish the marrow, and that's what stem cell transplant is all about. So there is, in terms of side effects, about a 2 to 3 week period after that when someone is still recovering their blood counts. I like to think of the side effects. We can summarize them in several ways. If you are going to have an appendix surgery or gallbladder surgery, a surgeon might say to you, well, the mortality risk of this procedure is probably, 5% or something. So one way of describing side effects of medical procedures is to ask this question: if we did this procedure for 100 patients, how many of the patients might possibly not survive it? With stem cell transplant, probably 1 to 3% is the mortality risk, maybe even better than that if we could measure it. So in terms of mortality, it's quite a safe procedure. Second question I get asked by patients is, how sick am I going to be during a stem cell transplant? Am I going to be unconscious? Am I going to be stuck in a hospital room or hospital bed? Am I going to be too sick to do things for myself? Or, what's going to happen? And I like to think of it in this way. It's a disease of thirds, 30% groups or 33% groups, thirds. So 1/3 of patients are able to go through the entire stem cell transplant procedure without spending a single night in the hospital. These are outpatient procedures for 1/3 of patients. They don't get that sick. They are able to eat and drink throughout. They function at home. They will have some tiredness. They will lose their hair, but unlike mine, it will grow back at some point. They will have some mouth sores sometimes, but they are easily managed at home, and they'll come to the office, to the stem cell program probably every 2 or 3 days or something for a checkup until they recover. The second group of patients, the second third of patients, will start as an outpatient, but at some point during the 2 or 3 weeks of the transplant, they might get a fever, or they might get an infection, or they might not be able to eat or drink well, and they'll be advised to come to the hospital and stay till the end of that 2-week period. And then there are another third of patients who will spend 2 weeks or so, 10 days to 2 weeks in the hospital. That's about how sick patients get with a transplant. Now, what are the results like? The results also I like to think of in approximately 3 groups. So there's one group of patients who will have the best possible outcome with a single transplant. So their disease becomes almost unmeasurable, or sometimes we cannot measure the disease. These tend to be the patients who will have the longest duration of time until the disease begins to grow back, because as you heard, stem cell transplants given in this way do not cure the disease. So almost everybody at some point in time will relapse. But there are about 1/3 of patients who get a very good response. Disease is almost not measurable, and those patients will have often a few years, sometimes several years, until the disease comes back. There's another third of patients whose results are not quite as good as that, but are still probably better than they would have done if they had just stayed on standard treatment. And those are patients with results intermediate between what I've just described and another third or fewer patients who do not get a very good response after transplant. And the question, one of the questions we have these days is whether those patients should then immediately get a second transplant, which is safe and effective, or whether those are patients who might do better with then going back to regular treatments. Transplants are not for everybody. Not everybody wants to take all of their lottery winnings in a single big lump. Some people like to take their melphalan or other treatments over a period of time. I would say probably in comparing the two approaches, the part that impresses me the most about transplant is that duration of time without symptoms or treatment, something that some people have coined an acronym for, and we'll call it the TWIST score, time without symptoms or treatment. After a transplant, it's possible to enjoy several months, sometimes a few years, sometimes several years of not needing to be on treatment for myeloma and not having symptoms of myeloma. Probably the most important of those is the ability to not be taking prednisone or steroids for at least a few years or something like that, and that's very impressive. So in a nutshell, that's what a transplant is about, and that, I think, is probably the most commonly asked question that I get. So if there are other questions, would you like us to take questions after each, or just wait till after the whole? Okay, yeah. So that's the long and short of it. Thank you.